Hi, so I'm here with Nadine, Professor Nadine Foster today. We met this weekend at Physiotherapy UK, and I'm pleased to have met Nadine before we're talking to her this morning. So thanks, Nadine, for being with us today.
No problem, it's good to be here.
So I'm wondering, first of all, Nadine, would you just be able to, we're going to talk about low back pain and management of low back pain, especially in relation to the Stratified Care Low Back Pain Symposium you did in Singapore. But could you just tell us a little bit about yourself for the people that haven't met you before or aren't familiar with you, so that we know your background and where you work?
Sure. So I'm a physiotherapist by clinical background. My PhD was in the management of low back pain. And really my interest in trying to improve the management of back pain stemmed from my PhD research. I conducted a large national survey of practice in the UK of physiotherapists and a current management of non-specific back pain. Now that was about 20 years ago, but really that really highlighted firstly it highlighted what are the most common patterns of physiotherapy practice, and perhaps unsurprisingly, exercise and manual therapy in broad terms with the key management tools and the physiotherapy toolkit. But it also really, helpfully, for me at least, highlighted the evidence practice gaps that we have in the profession about how we manage back pain patients and whether our management approaches are indeed informed by the best available evidence. Now, of course, by the best available evidence, I do mean evidence that comes from high quality research, but also combined with good clinical experience and patient preferences. But nevertheless, we can't avoid that best available evidence does include high quality research. And so really that enthused me to continue to do research in the field of spinal pain. And over the last 20 years, my research has broadened to be musculoskeletal in primary care in general. So some of my most recent research is in, for example, shoulder pain and other musculoskeletal disorders. But I've always remained very passionate about back pain management. And so my research portfolio has always included the management of spinal pain.
Great. So we've got a lot to talk about then over the 20 years of your research in low back pain. What were those, when you did your PhD, what you say you looked at physiotherapy practice and what people were doing, and exercise and manual therapy came up, but what were those practice gaps that you found?
Well, I mean, one very interesting one for me at the time was that, of course, at that stage we were moving towards the language of non-specific back pain. And of course, as physiotherapists, certainly 20 years ago when I trained, we didn't really use the language of non-specific back pain in our training. And that came across really clearly in my survey results, because what was very clear is that physiotherapists don't recognise, or at least didn't recognise, the condition of non-specific back pain. And yet much of the literature and the guidance that was coming out was all focused on non-specific low back pain. So leaving out the small group of patients with true radiculopathy and leaving out the patients, very small proportion of patients with serious spinal pathology. That was such a stark finding, is that all of the literature was being written and published around this thing called non-specific back pain, and yet we as a profession, we're still talking about lots of specific clinical diagnoses that of course may or may not be valid, and they may or may not ring true across other professional disciplines. And so that immediately highlighted a problem for us in taking research forward, because of course we needed to bring physiotherapists into an arena where they would feel more comfortable with the idea of non-specific back pain. And of course the whole growth of the biopsychosocial model then came around, and that was very much, in line with international thinking about the various different factors that can influence back pain and the experience of back pain. And then, of course, we had the rise of the flag system. So Chris Neal and Nick Kendall and colleagues talking about red flags, yellow flags, blue flags. And so it did seem to come together quite nicely, and all of that really underpinned where we took our stratified care research, because it kind of all provided the building blocks of thinking about non-specific back pain, thinking about these other factors other than just anatomical anomalies or pathologies like step joint, osteoarthritis, and so on and so forth, but thinking more broadly about this syndrome of back pain and how we might go about trying to match patients to treatments, irrespective almost of underlying physical anatomy and anomaly.
And I really like that answer you just gave. It really solidifies on the teaching we've been doing on this on the low back pain course that we've been running recently, which is great. So over the past 20 years since you did your PhD, and you've talked about how you've moved into researching treatment approaches that match the people's presentation. But how would you summarise the change in the management of low back pain over the last, since you've done your PhD?
Well, there have been some other large national surveys that I guess we better capture that information. I'm not sure I'm sufficiently familiar with all of the recent findings on those surveys, but certainly it feels that there has been a move towards acknowledging non-specific low back pain within our profession. And I do think that's helpful. Of course, it has some limitations, and we could discuss those as well. But I think the move to accept that even though we do a differential diagnosis and we might hypothesize different underlying structures, that we're more comfortable to consider the patient's presentation generally as a non-specific pain presentation. I think that has been helpful for us to move forward a little bit. I guess the other large difference I observed from 20 years ago would be that we were still using a great deal of passive modalities for the management of back pain. Certainly, my observation was that we did use quite a lot of passive interventions, particularly things like electrotherapy and traction at the time. And I've certainly seen a huge move away from that, certainly in the UK. Now, that might be different in other parts of the world.
That's great. And so that probably takes us into the work that you're doing now, that you've moved into on stratified care. And this was the work or the idea that you presented at the Low Back Pain Symposium in Singapore at the WCPT Congress. So can you just introduce us to your work on stratified care and sort of explain that model for us to help us have a better understanding of that?
Okay, so our landscape here in our research team is we're really focused on primary care or first contact care management of back pain. And of course that encompasses a very varied or heterogeneous group of patients coming to first contact clinicians. Most often in the UK, those are general practitioners or family doctors, but of course also physiotherapists, chiropractors, osteopaths, and so on. And really what we wanted to try and do is see if we could work out a simple and clinically useful way that could help clinicians identify patients in that first consultation when they come with back pain, to identify who will do well and who won't do well with the sorts of clinical interventions that we have to offer in primary care. And then to be able to systematically use that information. Again, it needed to be simple and simple enough to use in busy clinical practice, very short consultation times often, in general practice in particular. In the UK, a GP might have 5 or 7 minutes with the patient. And so we needed to come up with a system that was clinically simple, but helpful enough to guide decision making about which treatments to offer those patients. Because we think that in this large heterogeneous pool of patients in primary care, there are some that have a very good prognosis and they are going to do quite well, almost irrespective of the treatment that they're offered. And we don't want to over-medicalise those patients, and we certainly, in a resource-constrained health service, we don't want to be offering those patients unnecessary investigations and unnecessary expensive treatments. So we needed a way of spotting those folks who have good prognosis and reassuring the clinician that they don't need to refer those patients on, that they don't need to offer them expensive additional treatments, but that they can confidently reassure these patients about their ability to self-manage and their good prognosis. But that's only one side of the story. Of course, there are patients who we believe are at risk of poor outcome, that they are likely to need more than what those first contact clinicians can often offer, particularly those seeing their general practitioner. And that we wanted to equip clinicians with a quick way of spotting those patients who will help them say, hold on here, this is someone who I can't simply help to self-manage, provide some pain relief and reassure them that it will go away. these folks are likely to have longer term courses or longer term trajectories of pain and disability, and they're likely to need more in the way of active treatment. And so really, about 10, 12 years ago, our research team here at Keele in the UK set ourselves that challenge to try and come up with a system in which we could do two things. One is identify patients' risk of future persistent pain and disability, and then once we've identified their risk, be able to use that information to systematically match them to different treatment options that might better address their needs. And so that is stratified care. It's this tale of two components. It's about subgrouping, and then it's about matching to different treatments. And of course, there are lots of different ways to go about stratified care, and the symposium in Singapore was highlighting three approaches to that. The approach that we've taken here at Keele, because very much of the conversation we just had around non-specific back pain and thinking about it as a pain syndrome rather than as individual underlying physical anatomical problems, then we decided to focus on a prognostic model. And I did say earlier, that's almost irrespective of underlying physical pathology. Now, of course, there are patients who present with quite significant physical pathologies. And in our model, those patients are also managed. The caveat is that we have not yet focused specifically on those patients in true radiculopathy, and I see those as a specific subgroup of patients, at least until we can be reassured that they're not, that their prognosis and profiles are more or less the same, and they respond to treatments in more or less the same way. So our large body of research has been done with non-specific back pain in primary care. And we've been developing and testing a subgrouping tool called the StartBack tool that is a quick and easy tool for either patients or clinicians to complete in everyday clinical practice consultations. The tool is scored, and then the patient is allocated into one of three groups, either low, medium or high risk of persistent pain and disability. And then in our approach, we have matched those three groups of patients to different intensities of treatment, essentially. And that is all described in the publications or on our website that we've produced around those matched treatments.
And we can put links to that up available with this so that everyone can have a look at those. Can you, I know you've mentioned that we can go away and have a look at it. Are you able to briefly summarise what those sort of treatment options will be in those three different groups?
Sure. So because the low risk group, we feel are folks who have a very good prognosis, they're almost irrespective of what we do, but we want to provide good reassurance, help with pain relief, and essentially help the patient feel confident that they can self-manage their back problem. Then the match treatment for that risk group is a package of what we call good reassurance and good primary care. So it is about helping patients with pain, and that might be through pain medications or other advice around what the patient can do at home to help with pain. It is about giving them good written information about self-management with helpful tips about how they can do that at home and how they can get on with their lives, despite the pain at the moment, because they've got a good prognosis. And reassuring them about that good prognosis and about being confident to get on with their daily activities, including work, and that onward further investigations, such as MRI scans and so on, are unlikely to be necessary. Now that, of course, is in combination with the clinician's usual clinical diagnosis and clinical reasoning. And again, I stress we're talking about a non-specific pain population. And so that, coupled with our subgrouping tool, suggesting the patient is at low risk, is good reassurance for both the clinician and the patient that they do not need further investigations, tests, or further treatments. So that's the low risk group, yeah. And for folks in the medium risk category, in our UK health service, I guess one of the common treatment pathways for patients with back pain who need help in terms of further support to get active and to address the problems of pain and disability. In our pathway in the UK, that would mostly be offered by physiotherapists. And so it made most sense to us when we were developing our model of stratified care here in the UK that we would engage physiotherapists in offering matched treatments to patients who are at risk of further pain and disability. So the medium risk package really was a course of what we might call good or evidence-based physiotherapy intervention, and predominantly around our interventions of exercise with or without manual therapy, but all in the context of approaching this as a pain condition where physiotherapists are reassuring and helping patients identify ways in which they can manage pain and disability, but using a course of physiotherapy treatment sessions. Very much what we might call, good usual physiotherapy care in our National Health Service. And I think we protocolise up to 6 physiotherapy treatment sessions. Again, that would reflect what would happen in our usual NHS care here in the UK. Of course, I realise that in other countries, physiotherapy interventions can often be very, very much more extensive than that, and perhaps include 10 or 12 or 15 treatment sessions. But that is not what happens in our health service here in the UK. And then for the patients who are at high risk of persistent pain and disability, because the way in which the tool allocates patients into high-risk groups, as well as having significant physical obstacles to recovery, those patients also have quite a few psychosocial obstacles to recovery. The items on the tool, for example, are items that ask about mood, such as depression and anxiety, as well as things like fear avoidance and catastrophizing. And so because patients in a high-risk group not only have significant physical pain problems, but also significant psychosocial obstacles to recovery, we then developed a matched treatment for that group that we felt was a sensible approach of combining the best of what physical treatment can offer, such as that offered by physiotherapists, but with some new skills added to those skills or tools in the toolkit of physiotherapists, so that we could support physiotherapists to more systematically elicit and begin to address some of those psychosocial obstacles to recovery. So we called it a blended or integrated physical and psychosocial approach, but it was absolutely offered by physiotherapists in our health service. We didn't feel it would be credible to position psychologists at that front line for primary care management of back pain. Because remember, a lot of these patients, for a lot of these patients, this might be their first consultation. They're in physical pain, and of course their attribution of that pain is to problems with their spine. Physiotherapists have high credibility to manage that. But in addition, we felt it was then the right option to upskill physiotherapists to also begin to elicit and manage psychosocial obstacles to recovery. And so our team developed a training programme which physiotherapists took part in order to help them feel more confident and competent to address those psychosocial obstacles to recovery. So the really key thing to stress about the high risk subgroup in our approach is that it's not about dividing physical from psychological obstacles to recovery. It is indeed a model of complexity, and the folks who are in that high-risk group have significant physical disability as well as psychological, psychosocial obstacles to recovery. In other parts of the country, we know that teams are offering treatment to high-risk patients from psychologists. We felt that was not going to be the most credible and appropriate thing for primary care patients. But I'm absolutely open to the idea that that might also be a successful model, and we'll see research, I'm sure, coming out on that in the future.
Yeah, good, interesting. Ooh, sorry, that sound was a bit echoey. Really interesting, thank you. So 2 things spring to mind. The education toolkit package that you mentioned that you do for the high-risk group, is that available anywhere for people to access at the moment?
So if folks access our website, there is information there about the ongoing training courses that are available.
Yeah.
Our team are committed to continuing to offer training opportunities, and they are a combination of either coming to Keele to take part in our courses here, and they run ideally courses that have blocks of teaching where folks can go away and try these new skills out and come back. But our team also offer a course specifically for international visitors where they come for 1 block of time and cover all of the training material in that 1 week. And in addition to that, the team are developing online training materials, which will obviously be helpful in cascading the information about the training. Gail Souden one of my colleagues also led a paper that was published that detailed the content of the interventions if folks wanted to access that. And again, full information about that is on the website.
Okay, yeah, great. And then my other thought is kind of around some of the other sort of care models or that there are around in the world. So particularly the treatment-based model that comes out of the US, which is obviously, we talk about the Start Back tool is widely used in the UK, and I seem to see that the treatment-based model is widely used in the US, and that's what they talk about. And I can see that the two would fit really well together. My thought is that the treatment-based tool from the US would fit well with the medium risk patients. Is that kind of an approach to look at, or is that something that would work?
I suppose my view on that is that's a very sensible approach to looking at these different approaches to stratified care and seeing how they might be sensibly brought together. Of course, the caveat is that none of the research that either of our teams have conducted has addressed that specific question.
Yeah.
So the truth is that we don't know whether combining, let's say, manipulation clinical decision rules or exercise clinical decision rules that have come from the researchers in the US, we don't know if combining those with our, let's say, medium risk subgroup provides superior outcomes than not doing that. And of course, again, I guess what I would say is that I'm sure over time, as different clinical and research teams begin to really try to combine these approaches and test them, and I'm sure over time we'll know some of the answers to those. But for now, my feeling would be that that does sound rather sensible, because the stratified care approach that we've developed is very much about the front-end decisions, about does someone need to go to see someone like a physiotherapist for a course of physically focused intervention. And then, of course, when they see the physiotherapist, then other approaches such as the treatment-based classification systems might well help them decide which treatments to offer. So yes, it sounds sensible, but of course, I am a researcher, so I would say let's not wholeheartedly do that, but let's see if we can test it and test the hypothesis that might be a sensible thing to do.
And that came out in the symposium at the end when Mark spoke about, sort of looking forward into the future, that bringing all these different models of care together into a stratified package would be a really nice way to see it all coming together from around the world, so that everyone's work coming together, as well with Peter O'Sullivan's work with the cognitive functional work and others as well. So how...
Yeah, so maybe one of the, absolutely, and Mark did a really good job of envisaging how these things might fit together in a sensible way for clinicians. I guess, again, the only caveat I would raise to that is, of course, we're talking very specifically here about the physiotherapy profession. And we are not the only group that have a stake in the management of back pain. And so whatever we do that will make a big impact across all of patient care, I guess I would just want to ensure that it's transferable. So if we come up with really good approaches to management, it would be nice if those are transferable across the disciplines in a helpful way, because that ultimately is the best implication, not to only focus down one professional avenue. And because really some of the training and some of the skill sets that we're talking about for some of these stratified care approaches are very much in the hands of physiotherapists.
Yeah.
And that will always limit, to some extent, the impact of the patient.
Absolutely. Sorry, sound issues. And by other practitioners, you're thinking doctors, you've mentioned doctors and the psychologists that might get involved. Anyone else that you're thinking might be affected by this?
Well, certainly in the UK, chiropractors and osteopaths also play a big role in the first contact care management of back pain patients. Acupuncturists as well. I mean, once you move out of our National Health Service and into our private care arena, there are many other professional disciplines involved, including our medical colleagues.
Yeah.
And so I think we just need to keep an eye on ensuring that if the aim is really to improve patient care, then the approaches to stratified care, it would be very helpful if they have transferability and can be used by lots of disciplines.
Absolutely. I think that's great. It's a great to raise our awareness to that, definitely, and not for us not to stay so for us to keep an open mind about where this is all going. So I just wonder, what are your thoughts for the future for the management of low back pain? So you've been working doing that for 20 years. What about the next 20 years? What do you think? Where do you think it's all going?
That's a really interesting question, isn't it? So, and very pertinent for us here at the moment in the UK, our National Institute of Clinical Excellence guidelines, our NICE guidelines, are just in the moment of being updated and reviewed. And in 2016, we're expecting NICE to publish their new national guidelines for the management of back pain and sciatica. So it's really interesting time here in the UK. To try and update our national guidance and then use that guidance in clinical practice. So I think I would say two things in response to your question. The first is that it would be really good if a lot of focus could go into implementing what we already know to be good care for the management of back pain. So, almost irrespective of what future research shows, there is a very large bit of work to do around really tangibly supporting clinicians, services, payers and commissioners of services to use what we already know is good care for patients with back. That would make such a difference, even without more research, just implementing what we already know about good care and clinical recommendations from high quality systematic reviews and guidelines. That would make me very happy if we could crack that nut of implementation, supporting real change in clinical practice. So that we're not over-medicating patients, we're not over-referring, over-diagnosing, over-imaging, and we are able to help people realise that back pain ultimately is a syndrome of pain. It's a very common thing in everyday life. It's unlikely we're going to ever really be able to prevent back pain completely. And so helping people manage it appropriately, but yet maintain full function and stay at work, those sorts of things, I think we really need to invest time in. So that's the one answer. The second answer is, of course, I'm personally very excited by the work that's going on here in our team and elsewhere around the world on the idea of stratified. I think, having spent a lot of time doing large clinical trials that ultimately show either no differences between treatments or very little differences between treatments for back pain, it excites me genuinely to see that we might be able to improve patients' outcomes if we begin to get smarter at matching the right patient to the right treatment. So I think, given the early positive steps of that direction of travel, I think we're going to see more and more stratified care research happening. And I hope that just won't be around prognosis or clinical prediction rules. I hope that's going to be across the full breadth of things that we can think of in terms of helpful interventions for back pain. I'm very excited, for example, about the idea that we might begin to be able to spot meaningful biological mechanisms that underpin chronic back pain, for example, and that we might begin to be able to get smarter at matching patients to treatments based on their biological mechanisms.
Yeah.
We're not there yet, but I think that's where the future is headed. So not just biological mechanisms, but the idea that we will be able to get smarter at matching patient treatment. That excites me a lot, but that's a lot of work to do still.
And just picking up on something you said when you're talking about effective interventions, which interventions are you talking about when you say that?
In terms of implementing into treatment, into care?
Yes.
The first of those two answers? Yeah. So I'm talking about managing patients well in terms of spotting who doesn't need onward referral and manage them well in primary care. So making and supporting clinicians in primary care to feel confident, to reassure patients, to support self-management in a meaningful way, so patients don't feel dismissed, but feel as though they genuinely can self-manage. That when we refer patients through to clinicians such as physiotherapists, that we are using the best available evidence about what we can offer patients. My sense is the best available evidence is around activity, exercise, physical activity, physiotherapists are very well placed to be a key profession offering that support over a course of treatment sessions. So those are examples of things that I think need to be being emphasised more and used systematically by all clinicians involved. It is still unfortunately the case that patients have very varied stories about their clinical care for back pain.
Yeah.
And it would be lovely to think that in the future we no longer have to hear those stories again.
Okay, I think that's great. I'm really excited to hear you talk about the future and the matching with the sort of biology that we might find related to low back pain and all those sorts of things. I know there's a little bit of research coming out about that now, but yeah, looking forward to all of that. Will be interesting. So is there anything that we haven't covered that you'd like to say to everyone today, being respectful of your time? So just to give you a last opportunity to...
Yes, I suppose maybe a couple of things. One is a sort of very clinical applied thing, and one is more of a research endpoint. So obviously, as we develop all of these different approaches to matching patients to treatment, there is great potential for clinical confusion.
Yeah.
And we have to be careful about that. And so for those folks who are involved, for example, in teaching undergraduates or postgraduate students, they have a challenge because we're now seeing a growing plethora of different approaches to subgrouping treatment. And of course, in any one course, perhaps it's completely unrealistic to think that students can cover all of those and that we can help clinicians be confident in all of those. My sense would be that it would be a very good place to start to identify one that feels most appropriate for the setting of that course or the setting that clinicians find themselves in, and to become confident and competent in one of those approaches, but remain open to looking at the others and considering the others as skills and experience develop. Because what we don't want is a very clinically confused workforce about back pain management. And I guess the other thing that I would say around future research is that it's really, really important that we don't stop at just producing one study on a subgrouping approach. I can't emphasise enough the importance of conducting replication studies or impact analysis studies. So taking these new approaches and not just taking, the original study and saying, okay, therefore it works, but then rolling it out into your context, your clinical practice, and studying the effects of that. Because we don't honestly yet know whether these approaches really are transferable to different clinical settings, different countries, and that's really important for the implementation of this work, because we want to be thinking about our implementation and not just implementing these approaches in a blind fashion. I'll stop there.
I think it's a really good point of assessing the implementation of these models in your own particular situation and working environment, because they are so different around the world, which is what we're learning. But two very good points. I think not to confuse ourselves by trying to cover all bases with all models, but finding something that works for us and our populations and then assessing the impact of that. Really good. So thank you very much, Nadine, for talking to us today. It's been really interesting, and we look forward to seeing more about your work in the future.
Thank you very much. It's been a real pleasure to talk